Hi everyone, my name's Kadie Tierney, and I'll be presenting to the Pediatric Emergency Department today. I'm a student from Roberts Wesleyan University. So to set the stage, let's picture the emergency department. How would you describe it? Some of the descriptors I've heard and would use include loud, chaotic, unpredictable, scary, confusing, rushed, traumatic, overstimulating. All of these words, usually with a negative connotation, are true for any regular human who arrives in order to receive care, some in more severe shape than others. Now, for children who can't make sense of the why as to why they have to be there, emotions become heightened. They rely on their parents as a safe space and comfort who attempt to help them cope through their feelings. Now let's take it a step further since we know that the ED is stressful for all adults and children, and take into consideration children who have autism spectrum disorder. In the research that I did, Decker acknowledged that individuals with ASD are susceptible to sensory overload and dysregulation. This ultimately leads to poor behavioral responses, which can hinder the ability to receive care. Not only is this stressful for the patients, but also healthcare professionals trying to help the patient. For nurses caring for autistic patients having an outburst, it is their duty to assess and provide them care, but may be nearly impossible and at times unsafe. It is in the best interest of the healthcare team, along with the patient and their caregivers, to create an environment that will help patients with ASD remain calm and better regulate their emotions in such a stressful time. The PICO question I present to you today is, in children with autism spectrum disorder in the Pediatric Emergency Department, how does a sensory adapted environment compared to a standard environment affect behavioral outbursts? The learning objective I have for my audience today is, by the end of this presentation, the audience will have a better understanding of what types of environments reduce autistic behavioral outbursts, which will in turn reduce stress and promote therapeutic care in the Pediatric Emergency Department. So my patient population is pediatric patients with autism spectrum disorder. Some background on autism spectrum disorder is that ASD causes sensory overload that makes it difficult to process information and emotions. This dysregulation may present as behavioral lashouts as the patient tries to take control of a feeling or emotion while everything around them is uncontrollable. Unfortunately, these lashouts are dangerous for the patient. Some options that I have in creating a sensory adapted environment include dimmed lighting, a quiet environment, which may utilize noise canceling headphones. So this is where we could really focus on collaborating with social work to create a sensory kit for ASD patients, and that could include a couple of headphones and specific toys that could be beneficial when they're not present, since they often leave at midnight and then the night shift is left without any help for the rest of the night. Weighted blankets, avoidance of unpleasant smells, private rooms when possible, and sensory toys. So to compare, currently in the PEDS ED, there are no special interventions in place for children with ASD. When they arrive, they wait in the common waiting room for potentially hours with all of the other patients. Betancourt-Avero identified that waiting rooms in particular trigger disruptive behaviors and may actually increase the levels of interventions needed by the healthcare team. All of this will likely cause escalation before the patient can even receive any care at all. Then, when they finally do get roomed, it's unlikely that they'll get an individual room, especially if the patient volume is high. And as we know, there are only a couple of rooms that stay solo here since there's such limited space. So unfortunately, the overstimulation will continue once an ASD patient is seen for care in a room. The patient will not only be stimulated in various ways by their own care interventions, but also their roommates. As Betancourt-Avero acknowledged, the level of overstimulation results in severe anxiety, disruptive behaviors, or withdrawal. Nurses are expected to still build rapport and complete orders, but are not being set up for success in doing so. Some common themes in the literature pointed to reduced stress and anxiety for ASD patients with the use of sensory adapted environments. This response improves patient safety and compliance to enhance therapeutic interventions. Ultimately, healthcare professionals are equipped with adequate resources in order to better manage the interactions they're having with any ASD patients. Some keywords I used to find literature included pediatric autism and emergency department, autism and environment, autism and behavior, autism and emergency department, and pediatric autism and sensory. In the literature, I found several articles that supported and promoted the use of sensory adapted rooms for patients with ASD. Overall, the goal in this is to decrease uncontrollable stimuli, which in turn reduce the frequency of behavioral outbursts, helping healthcare professionals and the patient. Decker stated that the use of weighted blankets, noise-canceling headphones, and reduced noise, dim lights, and minimizing physical touch improve patient safety, comfort, and therapeutic engagement. Another source I utilized was written by Leonardi, who analyzed past experiments of the use of multisensory environment rooms for ASD patients. Having a multisensory environment room allows different patient needs to be met. As all care should be individualized, Leonardi explains that MSE rooms individualize sensory adaptations for each ASD patient need in order to reduce anxiety. One experiment from the past that was discussed was the use of a Snozellen room, which contains adjustable lighting, soothing sounds, and tactile elements. Not all ASD patients will have the same sensory needs, although common ground that minimizing stimulation helps control emotions. Creating a space like this is not only calming, but allows a safe space to explore, which can be beneficial in distraction. There are a few limitations to this intervention that need to be acknowledged. First, in the literature, pediatric emergency departments lack standardized care protocols and education in caring for ASD patients. This hinders the RN's ability to respond, de-escalate, and care for ASD patients effectively and therapeutically. Another key factor to recognize includes limited space. The ED is small and crammed with limited rooms and high patient volume, making it difficult to reserve individual rooms to children with ASD. But considering that Strong is building a much larger ED at this moment, a sensory adapted room is something that can be doable. Lastly, it will be an investment in order to provide nurses with the proper resources to manage ASD behavior. This includes sensory adapted rooms with sensory gadgets, such as individual rooms, limited noise, noise-canceling headphones, sensory toys, weighted blankets, weighted vests, lights, etc. To a hospital, the idea may sound like a lot, but this intervention ultimately protects the patient from further trauma. And for future research, a goal should be to develop standardized protocols in caring for pediatric ASD patients that will best guide the RN in providing care. This will hopefully limit the amount of behavioral outbursts and assist RNs in navigating the complexity of emotions throughout their time in the ED. And lastly, the role of the RN in all of this is to provide therapeutic care, therapeutic interventions, and promote therapeutic communication. It is crucial to advocate for the patient to have the best success. This could be discussing with the charge about having an individual room or switching roommates, getting child life on board when they are there, and working with mom and dad to utilize their resources and what they know works well for the child, and continuing to talk to the provider throughout the patient's care. And of course, education still continues in the RN role here. We can continue to educate mom and dad on coping skills and resources during times of sensory overload and stress to help them navigate the difficulties as well as we attempt to de-escalate emotions and any behavioral responses. And lastly, here are the resources that I used and the literature that I used. Thank you all for attending, and thank you for your time.